Hello and welcome to Renal Function. First, we're going to look at the renal functions and anatomy. As you can see in the top right-hand part of your slide, we've got several parts to the renal system. The kidneys are located on retroperitoneally on either side of your spinal column. You've got two ureters that drain the kidneys into the bladder, and you've got one urethra. I notice a lot of students sometimes forget, oh, do you have two ureters? Do you have two urethras? They get ureters and urethras confused. I had a medical terminology instructor that used to say urethra Franklin. She's the one. So urethra, they sound kind of the same. I don't know if that helps you memorize it, but if it does, go with it. So the main function of the renal system isn't just to remove water from your body. Everybody just kind of assumes that you drink water, urine comes out. Well, it also does the removal of unwanted substances from the plasma. It balances your body's water, your electrolytes, that acid-base status, remember we learned about that last quarter, and hormonal regulation as well. So it does quite a few things. Again, the different anatomy that you have, you've got the two kidneys, bean-shaped on either side of the spinal column. You got two regions inside each kidney, the cortex and the medulla, and we'll talk about that on the next slide. You've got two ureters. They're thick-walled canals connecting the kidneys to the bladder, which is kind of the storage area for the urine before it's excreted through the urethra. A very, very important piece that we're going to talk about in the next couple slides as well are the nephrons. The nephrons are the functional units of the kidney. Approximately 1 million nephrons are found in each kidney. So here's an up-close picture of a kidney that is divided in half to kind of show you the inside. You can see the pelvis of the kidney where the urine ends up draining into before it goes to the ureter. But before that happens, there's a very dense blood supply that goes to the nephron. The first part would be the glomerulus. Then it goes to the proximal convoluted tubule located in the cortex. The loop of Henle extends down. You can kind of see these guys coming down into the kidney. We have a distal convoluted tubule and a collecting duct. So there's different pieces to the nephron that allow the concentration of urine to happen. So we're going to talk about each of those pieces and what they do. So here's a representation of a nephron and the blood supply that comes to it. You can see the dark arteries here and the veins. The arterial blood is delivered to the nephron via this glomerulus here. So we're going to talk about each of these pieces coming up and how that travels through to the final station, which is the bladder. So the first piece that happens is glomerular filtration. You have these arteries here that deliver blood via the glomerulus, okay? And the Bowman's capsule is this C-shaped ring that is around the outside of it. This is where the semi-permeable basement membrane allows protein-free, cell-free fluid to pass from the blood into the proximal convoluted tubule. Okay? So it's got a very high pressure in these glomerular capillaries. It's got that semi-permeable basement membrane. There's a net negative charge, so it repels away any large proteins. We don't want proteins, we don't want cells in our urine. Okay, we want to keep those things in our body. So out of 1,200 to 1,500 mils of blood received by the kidneys, the glomerulus filters out 125 to 130 mils of protein-free, cell-free fluid, also called glomerular filtrate. What we can do and tell the physician as well is what the patient's glomerular filtration rate is. That is the volume of blood filtered per minute. And we determine this by doing a creatinine clearance that we're going to talk about in a little bit. Okay, so let's go over each of the tubules after we're done with the glomerulus and the Bowman's capsule. So the next stop is going to be the proximal convoluted tubule. That is the one that's in the closest proximity to the Bowman's capsule and glomerulus. What happens here is we return valuable substances to the blood. We reabsorb 80% of salt and water. We don't want to get rid of all of our water. And we also reabsorb glucose into our body. So not only do we not want protein in our urine, we don't want glucose in our urine either. We need to keep that very valuable energy source inside of our blood. So anything there would be returned back to the bloodstream. Okay, so as you can see, the arteries and veins are interwound through the proximal convoluted tubule, loop of Henle, etc., to help remove those substances back. It also secretes some products of metabolism. The next stop is the loop of Henle. You can see this drops down and comes back up. This area aids in the reabsorption of water, sodium, and chloride and is a very important player in adjusting for osmolality. We don't want to have too high of an osmolality or too low of an osmolality in our blood. So this is where you're going to start adding these things back in. The distal convoluted tubule is the furthest distance from the glomerulus, and he adjusts for electrolyte and acid-base homeostasis. This is where ADH and aldosterone come in to control the amount of water and electrolytes that are reabsorbed and secreted in this area. So if you go back a couple chapters and remember what aldosterone and ADH do, aldosterone's a big important player for sodium, and ADH controls water. The last stop here, the collecting tubule, or the collecting duct it can be called as well, is the final site for concentrating and diluting urine. Here, ADH and aldosterone also control the reabsorption of sodium, water, chloride, and urea. It's also the final urine concentrating site for the kidney. Here's another pictorial of going back a little bit of the things that are controlled by the kidney. Aldosterone, as you can see on this side, when it increases sodium reabsorption, which increases plasma sodium, which increases your osmolality. So as you can see, sodium is the chief plasma cation in regulating this osmolality. Some other things that the kidneys do are eliminate our non-protein nitrogen compounds. We learned about these prior to this section as well. Urea is readily filtered by the glomerulus and reabsorbed in the collecting ducts, and that is the primary excretory form of nitrogen. We learned about that last quarter. Creatinine is readily filtered by the glomerulus. It's not reabsorbed by the tubules, and it's directly proportional to the muscle mass and remains constant from day to day. This is the best indication for glomerular filtration rate, is how the creatinine level is within the body. Normally it stays much the same. Urea, on the other hand, is constantly increasing and decreasing a little, but creatinine, because it's proportional to the muscle mass, is very constant, and if that fluctuates, it tells us there could be a problem with the kidneys. Uric acid is another one that's readily filtered by the glomerulus, but he undergoes a complex cycle of reabsorption and secretion as it passes through. So while he is increased in renal failure, just like creatinine and urea, it's going to increase and decrease a little bit. So it's going to be not as good of an indication as how well the kidneys are filtering. But if you do have renal failure, all of these, urea, creatinine, uric acid, will all be elevated. One of the next things that the kidneys do is a water balance. Okay, we talked about this with the distal convoluted tubule and the collecting duct, but the increased plasma osmolality or decreased intravascular volume stimulates the secretion of ADH from your posterior pituitary. Okay, so if you're a little dehydrated or your blood pressure goes too low, your kidneys act on it by getting the message from ADH. Once it gets the message from the ADH, it increases the permeability of that distal convoluted tubule and collecting ducts to water, causing increased water absorption. So it causes you to keep more water and not urinate more water out because you want to increase the blood pressure or decrease the amount of solids in your floating in your bloodstream, essentially is what osmolality is. So you want to add more water to that situation. Another important player is that aldosterone. Remember, he comes in with a response to low blood pressure by increasing sodium and therefore increasing water, etc. So remember, aldosterone and ADH regulate water. All right, the next step here is electrolyte balance. So the kidneys are very, very important in controlling these. Sodium, the major extracellular cation, you do have to remember that, is controlled by the renin-angiotensin-aldosterone hormonal system and is regularly excreted by the kidneys. Potassium, remember that's your primary intracellular cation. It is reabsorbed and excreted by the distal convoluted tubule and collecting ducts, and its excretion is controlled by aldosterone. Chloride, the negatively charged one, is the primary extracellular anion. He is passively reabsorbed as a counterion when sodium is reabsorbed in the proximal convoluted tubule. Sodium and chloride always kind of work together to keep some balance there. It can also help control phosphate, calcium, and magnesium when needed. Acid-base balance, we learned about this at the end of Chemistry 1 when we talked about blood gases. It can do the regeneration of those bicarbonate ions. A sodium bicarbonate and blood pH give a great indication of the acid-base balance function of a patient's renal system. Remember, if you've got a lung issue that's causing you to be too acidic, your kidneys can hang on to more sodium bicarb and help buffer the pH in the patient's bloodstream. We can also do the excretion of metabolic acids. Waste products would include carbonic acid, lactic acid, keto acids. So if those things start to build up, we can start to eliminate those via the kidneys as well. And then ammonia. If we are eliminating just pure ammonia, it combines with hydrogen ions and is excreted as ammonium ion. So you don't actually just urinate ammonia, it's ammonium ion. So not only do we have electrolytes, acid-base balance, water balance, we have some endocrine function, which refers to the hormonal function of the kidneys. The kidneys are able to synthesize the following, such as renin. Okay, renin is something that the juxtaglomerular cells secrete renin in response to a decrease in extracellular fluid. So it is able to pick up your blood pressure and know what it is to help synthesize angiotensin to raise blood pressure. Pretty cool. Erythropoietin, you should have learned about this in your hematology course. This one acts on erythroid progenitor cells to increase the amount of red blood cells. So that is picked up in the kidney as well. Low oxygen levels cause the kidney to excrete more erythropoietin to cause the body to create more red cells. Then we have the 1,25-dihydroxy vitamin D from our last chapter. This is the active form of vitamin D. It has to start in the skin, then it goes to the liver, then it finally ends up at the kidney where it becomes the active 1,25-dihydroxy vitamin D. And this determines the phosphate calcium balance and bone calcification. Then prostaglandins, these are a quick, fast way to increase renal blood flow and blood pressure. It opposes renal vasoconstriction, so it can help control the blood pressure levels at a much faster rate than some of the other things can. So now we're finally going to get to some of our analytic procedures that we actually do in the laboratory. The first one is going to be a clearance, specifically creatinine clearance. You will need to be responsible for knowing how to do this calculation, not just for my test, but for your boards, etc. So creatinine clearance is the evaluation of renal function depending on the measurement of waste products in the blood that accumulate when the kidneys begin to fail. So I have a story about a man who I would say is about 25 years old. I was working a Saturday shift at a local hospital. And no, it wasn't a Saturday, it was just a regular evening shift, now that I think of it. And it was a clinic patient. So what happened is we had all the clinics next to the hospital would send a lot of their blood samples to the large hospital, and we would run those on the evening shift. And back then I was working the 3 to 11 shift. I was running along with all my samples, everything was going fine. And all of a sudden I get a flag on a patient, and the patient was a 25-year-old male. And the creatinine level, which is normally 0.5 to 1.5, was 14 milligrams per deciliter, when it's supposed to be 0.5 to 1.5. I thought, holy crow, that's crazy. I look at the sample looks good, put it back on the analyzer, and I run it again. And upon running it again, I get the same answer. So what this does is it strikes you to have to call the physician and let the physician know what the result is, because it's a panic value. So I called the physician, who happened to be my physician, which made it even more fun. And I told her what the result I got was, and she's, oh my gosh, she couldn't believe it. And especially having seen this 25-year-old male in her office that day with high blood pressure. So she put him on some blood pressure medication. Well, anyway, she calls the man at home, and he comes in to the lab, and I had to draw him again. He looked fine to me. I don't know. So I said, well, the doctor wants me to draw this again. I'm going to run it again, and she wants you to stay here till the test is done. So I had to draw the blood, and I ran back. It was 15 milligrams per deciliter, so it even had gone up a little bit. So I handed the phone to the patient, and she had a conversation with the physician, and I had to walk the patient to the dialysis unit. Healthy young 25-year-old male. He ended up actually getting a kidney transplant probably a couple months later, and I remember being there through that whole process, and he was in the hospital for a while after that as well. So what the test that I did on him was a creatinine clearance. It's a great test to determine renal impairment. For some reason, his kidneys just gave out on him. Don't know why. Didn't ask. I don't even know if they really know. So if that patient was obviously very severe, but if somebody seems to be having some creatinine issues, we can actually do a creatinine clearance rate to determine the actual rate of filtration. So he was a very severe case, but sometimes it's just slightly elevated. So they want to figure out what's going on. So we will use this calculation that you see here to do a glomerular filtration rate. I'm going to give you one that's a little bit easier to read than this. So here is the calculation that we're going to use. We have the creatinine clearance, which is the name of our test. We need to run a creatinine test on the urine. We need to measure the amount of urine that comes from the patient in 24 hours. So they have to take home this giant jug, which is usually 2 liters or so, the jug is. And we send him home with this jug, and they have to urinate in it for 24 hours. Okay? But we have to do it in minutes. The volume has to be mils per minute. So I'll show you how we get that in a minute. Then we have to draw the patient's blood, which would be the plasma creatinine. We multiply it times 1.73, which that number is always there, divided by the patient's body surface area. Most lab computer systems have a way of calculating body surface area when you enter in the patient's height and weight. All right, so let's do a sample creatinine clearance problem. We're going to use the creatinine clearance calculation that you have to memorize, which is in the top right-hand part of your screen. So, patient comes in, drops off a jug full of urine. We have to take that urine, mix it really well, and we have to test it on the chemistry analyzer, just like how we did with our spectrophotometer, but the analyzer does it for us. It's a little faster. And we get 200 milligrams per deciliter. The amount of urine in that jug was 1,500 mils. The plasma creatinine, because we had to draw the patient's blood, was 2 milligrams per deciliter, slightly elevated. Body surface area, probably a larger male, 2.1. So here's what we're going to do. I'm going to pull up the whole calculation here. We have to take the urine, because you can look up here. Urine is 200 times mils per minute. We have to take the volume of 1,500 and divide it by 1440. That is how many minutes are in 24 hours. We give the physician the results in mils per minute, so we have to use the amount of minutes in 24 hours. That's 1440. Divided by the plasma creatinine, which should be 2.0 here, times 1.73 over 2.1. I apologize for the error on the bottom on that side. Your answer should be approximately 81.7. I can't guarantee you that's exactly what it is. Let me use a calculator here and see if that 2.0 changes it. 1,500 divided by 1440 times 200 divided by 2 times 1.3 divided by 2. Okay, so it actually comes out to 85.8 mils per minute. Okay? So this would be 85.8 mils per minute if you change this guy here to 2.0. Okay, so that would be our answer. Okay, so the reference range for males is 97 to 137 mils per minute, and the females is 88 to 128 mils per minute. So as you can see, this person would have a slightly decreased glomerular filtration rate, so it's not filtering as fast as they should be. Other clearance measurements that you can do would be, one would be a urea. That one does not provide a great clearance assessment, and it's not widely used anymore. Reason being is it fluctuates throughout the day. It can be, it just goes up and down. Creatinine doesn't have as much variation, therefore it's a much better clearance to use. Some other tests we do, we can look for a Bence-Jones protein if someone has elevated amounts of protein in their urine. We can do additional testing to see if it is a Bence-Jones protein, which would be if they had multiple myeloma. We can do a urine electrophoresis, which takes the proteins in the urine and separates them out to determine whether they have a glomerular nephropathy or a tubular issue, to see where the proteins are coming from. We can also use it to see if they have something called a monoclonal or a polyclonal gammopathy. Those are things you'll learn about in the immunology class next quarter, but some examples that you might find with electrophoresis would be maybe somebody having multiple myeloma or Waldenstrom's macroglobulinemia. Beta-2 microglobulin is another one that we can look for if they have that protein in their urine. It could be elevated if there is some kidney transplant rejection. Myoglobin is another one. We can do myoglobin on the urine to see if there could be renal failure as well. Another one that we do a lot of is the microalbumin test. Microalbuminuria refers to having small amounts of albumin in the urine. It's very important in the management of patients with diabetes. Diabetes can be very, very challenging on those kidneys. Now, if we can find tiny, tiny, tiny amounts of albumin in the patient's urine early, we may be able to reverse some of this kidney damage or stop it from getting any worse. If it starts getting very elevated, it means there's a lot of damage to the kidneys, and it allows amounts of albumin to pass into the urine, which we don't want to have happen. If the patient does have urinary albumin concentrations of 50 to 200 milligrams over 24 hours, it is predictive of diabetic nephropathy, which is not a good thing to have. Another thing that we've all had done is a urinalysis. You guys get a whole entire quarter of urinalysis coming up pretty soon. Very cool what you can tell on a patient just by looking at their urine. Such a fast, easy, painless test to do. This permits a detailed, in-depth assessment of renal status. It also serves as an indicator for glucose and hepatic biliary function. When we do a urine, we look at the physical characteristics. For example, is it yellow? Is it red? Is it cloudy? Is it clear? We do a chemical analysis, which does it have glucose? Does it have bilirubin? Does it have nitrates? There's a number of things we can look for. We also centrifuge it and look at the sediment to see if there's any bacteria, any white cells, red cells, casts, all these wonderful things that you'll get to learn about. So here's just a list of some of those things. You do not have to memorize these for a quiz or an exam, but these are some of the things we look at for physical characteristics, some of the chemical things that we might test for. Some of the sediment that we look for when we centrifuge it, you can see we got some bacteria and some white cells. We can also find crystals. These are pretty cute. These are called triple phosphate crystals. We call them coffin lids. And that can be indicative of the pH of the urine or some other things that they may have going on. So let's look at some of the diseases that you can have just by looking at the urine, the things that we can tell. Glomerular nephritis is our first one. Glomerular refers to the glomerulus. Nephritis refers to an inflammation of. If somebody has acute glomerular nephritis, they usually have large inflamed glomeruli with a decreased capillary lumen. We see a lot of hematuria or blood in the urine, a lot of proteinuria or protein in the urine, and oliguria, which is scanty urine, not very much urine. We have increased serum BUN, and maybe creatinine as well. Now when you look over here, these are red blood cell casts. It looks like there's red blood cells in it. We see these in the urine. All of those tubules that you see in the pictures that we talked about, the proximal, the convoluted, loop of Henle, they're all tubes. This cast here is formed in those tubes, okay? So it actually bleeds into those tubes. There's a TAM horsefall protein that is produced inside those tubes, which make those red cells kind of stick together in what we call a cast. Now, on the other hand, chronic glomerular nephritis is glomerular scarring and eventual loss of functioning nephrons, so it's over time. We see gradual development of high BUN, and that's usually a first sign. The next one, nephrotic syndrome, this one's pretty serious. This is associated with massive proteinuria, hematuria, hypoalbuminemia, and edema from that, having high lipids in your urine, having high lipids in your bloodstream, and a decreased glomerular filtration rate. It's not a good situation to be in, difficult to reverse. Pyelonephritis that you see on the bottom right-hand corner here, many bacteria, we see WBCs in the urine and WBC casts present. This means that you have pretty much a kidney infection. We have the cast like we had with the glomerular nephritis, but pyelo refers to pus and pus refers to white blood cells. And those white blood cells form the cast with that TAM horsefall protein again. In those tubules, they kind of get jarred loose and they end up in the urine, and we see them in the urinalysis department. So we're able to tell the physician they probably have an infection that's all the way up in the kidneys at that point. Some other issues we can just have a general tubular disease, and this can result in decreased excretion or reabsorption of certain substances. We can have a renal tubular acidosis, which can affect the acid-base balance. A more simple thing that can happen is a urinary tract infection. If you're female, a lot of you have had this before. And this is either in your kidneys or your urinary bladder, which can be called cystitis. Another issue that can happen is an obstruction in the upper or lower tract, or kidney stones, also called renal calculi. And those can be formed by a combination of various crystallized substances that you'll learn about in the urinalysis course. One of the more unfortunate things that can happen, is renal failure. We can have acute renal failure, which happens quickly. Chronic is a gradual decline over time. We can have renal hypertension, which is caused by decreased perfusion to the kidney. This results in a damage to the glomerulus, and we see red blood cell casts in there as well. If we do have acute renal failure or severe chronic renal failure, they do end up on renal dialysis. And dialysis is the removal of waste from the blood by an external synthetic membrane. Then we also have therapy for end-stage renal disease, which usually is dialysis and or transplant. I'm going to end here with a couple terms that you need to be familiar with. Anuria pretty much means the absence of urine. That would be a urine output of less than 100 mils a day. Oliguria is urine output of less than 400 but greater than 100 mils a day. And polyuria, which is a urine output of more than 2 liters a day. That concludes our section on the renal function.